Hello. Welcome again to another session of Digital Slide Review and Sign Out. I'm Dr. Louis Hassel, coming to you from the University of Oklahoma Health Sciences Center. Our case today comes from the noted Stevenson Cancer Center located here on our campus, an NIH-designated cancer center, and involves a 65-year-old woman who's experienced weight loss and a mass in the tail of the pancreas is discovered. Representative images are obtained demonstrating a quite large mixed solid and partly necrotic mass emanating and connected to the distal portion of the pancreas, potentially compressing the spleen, at least displacing other structures and certainly accounting for her sensation of early satiety and loss of appetite. When the lesion is resected, it's found to have a very hemorrhagic appearance, a soft red, partly necrotic tissue, several centimeters in size, and have a connection to the pancreas with not too much identifiable ductal connection per se. Microscopically, there is a lot of necrosis in this tumor. And it's clearly invasive and destructive of the pancreatic parenchyma. Of note, however, we'll see that the tumor has a component of what appears to be, here you can see glandular differentiation with small glandular formations and atypical cells, some mucinous material in the lumina of these cells. Okay. However, adjacent to this and nicely transitioning from areas of this is this very hemorrhagic area, which is notable for quite a readily identifiable degree of pleomorphism and anaplasia with abundant giant cells. So as we look at these cells, we note there's almost, you might say, there's large multinucleate giant cells, but we also have some very bizarre atypical cells along with them, which some of which may be histiocytes, but others of which appear to be clearly malignant. Of note here, there's a nice transition from the well-differentiated component here, or at least better differentiated glandular component, merging into this more hemorrhagic and anaplastic type appearing area. Here we see a gland just sort of merging into that. So this is an example of a very anaplastic carcinoma. Here we see a gland within this portion as well as these other high-grade malignant cells, and we can see here some atypical mitotic figures in this very high-grade tumor. But it's one that is coexisting, perhaps arising from an area of more conventional type ductal adenocarcinoma of the pancreas. And this obviously accounts for the necrotic appearance, the very hemorrhagic appearance that we saw grossly to have this kind of tissue here. So undifferentiated carcinoma with osteoclast-like giant cells is most frequently encountered in the head of the pancreas, but perhaps a quarter of cases will arise in the body or tail. Male and female incidence is roughly similar, maybe slightly more common in women. And this is a lesion that is occasionally associated with conventional ductal type carcinoma, but that is indicative of a poorer prognosis. It can also arise in conjunction with mucinous cystic neoplasm or intraductal papillary mucinous neoplasms, which may or may not, in some instances, have osteoid. Of interest, and perhaps as would be expected in this sequence where there's a conventional carcinoma involved, many of those mutations that one sees with conventional adenocarcinoma of the pancreas, KRAS, SMAD4, PT53, CDKN2A, and so forth, are seen in these lesions. However, in addition, you may also find GLI3 and SERPINA3 to be developed as well. immunohistochemistry, there is retained keratin positivity in the malignant cells, but you'll also be able to identify histiocytic and osteoclast components in these tumor cells as well. So our final sign-out diagnosis today is undifferentiated carcinoma with osteoclast-like giant cells of the pancreas arising in association with conventional ductal type adenocarcinoma. So we don't see those very often. I thought we'd share that case with you, and hope that you'll likewise find it interesting. Comment below if instances where you've seen this type of a lesion, and certainly share your thoughts and comments below. And of course, we always welcome you to subscribe. So until next time, thanks for joining us.